welcome everybody. We are going to make a start here. It's so good to see everybody and that you've joined us for our webinar. It's called Building Capacity in Patient and Public Involvement Leadership. And this webinar is the first part of a mini-series, all under the umbrella of the National Children's Health and Maternity Priority Programme. This is part of one of the NIHR's, the National Institute for Health Research priority themes. So we're approaching this event as a shared learning opportunity. We don't want to teach you. We want to come together as a community of people that have a passion for public involvement. So above all, we would like to come together in the spirit of generosity. So hi, this is me. I'm Naomi Morley. I'm a researcher at the University of Exeter. And I work in the Patient and Public Involvement team for the Applied Research Collaboration Southwest Peninsula, such a mouthful, PenARC for short. And I work on the Children's Health and Maternity Programme. And in support of the public involvement there, I've started a community of practice where researchers and public collaborators, one of them is Mary, come together to share learning, their approaches to public involvement, and really develop that good practice through collaboration. So at the center of it is partnership and shared values. And Mary approached me about a year ago and proposed that we should take some of those values and the learning that we had and the challenges from the community, but also the wider network, and form a mini-series. So thank you to Mary. But I'm going to hand over to Mary now.
Great, thanks Naomi. So I'll leave you to press the admit button now while I'm speaking. As you say, great that we've got so many people who are joining us this afternoon. So I'll just tell you a wee bit about myself. I came to public involvement in research as a maternity services user, and I'm very aware that people who are involved in public involvement, organisation and leadership come through different routes, and perhaps the service user route is a minority route. What prompted me was that I'd had a mixture, some really positive experiences, and particularly with my first baby's birth, really difficult experiences. But I've made my whole career in maternity, working primarily in the third sector for charities, and also now I work as a freelance worker full-time, really, mainly at any rate in maternity research, facilitating public involvement. And I work with the Applied Research Collaboration, or ARC for short, in South London. Some of my colleagues are here today, so that's lovely. And once a year, we have an advisory group 3 times a year, as a sort of general way of learning about projects within the theme. And once a year, we have a public involvement strategy group where we can really think about policy and practice and sort of higher level principle things about how we're doing. And we had our meeting focusing on capacity building last November, and it was after that Rachel and Rachel, who was speaking today, Rachel Rowe and Rachel Placzynski, kindly spoke at that meeting, and then we went on to have a conversation with Naomi. But there seemed to be a real need for a lot more support, signposting to communications and relevant information, and training opportunities, and this whole thing about being recognised as a community of interest. So I think it's from a place of unmet need that we've set up these webinars, and it's partly to share our knowledge in a very collaborative way. And it's partly together as a group to identify need for further infrastructure and whatever you all come up with. So I'm going to go straight to introducing Felicity Shenton, our first speaker from the ARC, North East and North Cumbria. And what better title to start with than developing a peer researcher community of practice. Thanks, Felicity.
Excellent. So thank you very much for inviting me today. I'm the Public Involvement and Community Engagement Manager for the ARC in the North East and North Cumbria. And in this region, we have started work at the beginning of this year on developing a peer research community of practice. So why did we decide to do this? Myself and colleagues from FUSE, which is the translational research institution based in this region, became aware of a number of kind of things that were going on, some really good practice that exists within the region, some of it within the voluntary community sector, some excellent peer research going on, some fantastic work going on with a peer action collective, which is a young people's peer research project, and lots of requests for things like tools, training, resources, but also we became aware of people scrabbling around trying to find these resources and reinventing the wheel. So people saying, I want to do a peer research project. I don't know if there's any training available. I'll pull together what I can find from Googling stuff or pinching stuff or customizing things that I've seen and read and heard about. So a lot of reinventing the wheel, not using existing capacity that we know exists in the region, and not using it to the kind of best of our ability. But on top of that, in this region, we have a fantastic collaborative ethos across all of the research institutions that is underpinned by something called the Creating Connections Network, which is all of the PPI leads from across the ARC, CRM, the Clinical Research Network, Research Design Service, and all of the other funded research infrastructure organisations. So there's a real willingness to share and to collaborate in this region, which is fantastic. So we FUSE, people from FUSE, and I know we have members of FUSE in the audience. I've seen you here, so it's great to have you along. We decided to develop a community of practice, and I've just put a definition there about what we believe a community of practice is. And the aim of this community of practice was to pool learning, to create new knowledge, and to take some of the new learning and knowledge back into our own organisations and institutions. And we developed this with the shared values of openness, honesty, a lack of judgment and confidentiality. And I think those principles are really important as part of the development of the community of practice. So we started with an event in January of this year, a face-to-face event, which was held at the Gala Theatre in Durham, which was the kind of inaugural event. And that brought together people who were had delivered peer research projects, people who were involved in training, delivering training around peer research, and also people who had developed their own resources. And then we ran a number of tabletop discussions based on the 6 Thinking Hats model, which proved very valuable. We had a very mixed audience of public contributors, researchers, practitioners, and so on. So the Thinking Hats exercise proved very useful. I'm just going to whiz through these. This is just some feedback from some of the Thinking Hats process that we used. It's not something I'd come across before, but it was really useful. So we looked at the benefits of using a peer research approach to health and care research, and I won't read those out, but you can see what some of the benefits were from the people who've been involved. We looked at some of the things that might go wrong or had gone wrong. It's really important to learn from things that haven't worked in other organisations and with work that other people have carried out. I think you learn as much from things that haven't worked as you do from things that have. So we looked at where we might need to be cautious and where things haven't worked. We looked at what we wanted to happen. What were the things that, we wanted? What were the things that we needed? So there was an endorsement of there being the need for more peer research. There was a request for research on peer research itself. So how do we know it works? People say it was a great idea. It's a really good model. It's a really good way of getting communities involved, of getting the people with lived experience in a particular area of treatment or a particular area of service to be involved, because they are the experts. But we need to know I think that's a good thing. I've been involved in a number of projects, but we need some really robust evidence of the impact of peer research, what works and what doesn't, what motivates peer researchers and how best to support them. So there was a need for some more kind of exploration of peer research. We looked at some of the things that people wanted from this community of practice, and they wanted some clear definitions. There is a lack of clarity. I've heard colleagues from within my own institution talking about peer research and peer support interchangeably. They're not the same thing. So I think it's really important that we have some very clear definitions and defined principles, and we can agree those as a region. Some standardised and accredited training for academic researchers and for peer researchers, and I'll come back to that. To collate and share resources so that people aren't scrabbling around to try and find things that other people have accumulated and developed. To promote and showcase good practice, particularly for researchers, but also for communities. And there was a big call for that to be using creative methods and not academic conferences, academic presentations, and so on. And to educate and join up conversations between funders and peer researchers. I think there is a lack of understanding and commitment from some of the big funders. I think they think of peer research as something that is a kind of a nice thing to do rather than a process that results in some really robust evidence from communities. So the next event was an online event which took place in June, and at that we brought together people who have been working in this region and from outside who have some excellent experience in training and development. And then we brought Angela Broadbridge, who has worked in this region in a number of different capacities but has a really good track record of developing a peer research network in the region through the Changing Lives initiative. Chelsea McDonough came from the Young Foundation, which those of you know is a national organisation that has some fantastic training resources, an accredited training programme, which they are happy to customise and deliver to individual organisations, individual community groups. And then some researchers and peer researchers from University of Teesside who delivered a presentation on some work that they'd done in a really tricky, really challenging area of work. And they demonstrated the worth of doing peer research in an area of very challenging and sensitive practice. Next steps, we have an event, another face-to-face event coming up this autumn, date as yet undecided. And again, that will be a mixture of people presenting on work that they've done, but also discussing as a community of practice what we want to happen next, what expertise we need to bring into the region, what issues and tools we might have to share. There is now a space on the ARC's website as a repository for tools and resources, so that when people are looking for things, there's one place to go, which is proving really invaluable, and that's obviously open to anybody to use. And if people have resources that they'd like to share, we'd be really happy to upload them to that space. We have an Autism in Schools project, which has been funded by the ARC. I run a young people's advisory network for the ARC. They did a fantastic piece of work in reviewing a number of research proposals right at the outset of our ARC. ARC in the North East is one of the new ARCs. They did a fantastic piece of work doing some research prioritisation and reviewing research proposals. At the end of that, we wanted to give something back. So we said to them, right, you've done some fantastic work for us. What could we do for you? A number of those young people are autistic or who have family members who are autistic, and they wanted to carry out a piece of their own research. So we have a piece of work that is going on now that involves the mental health impact of an autism diagnosis for students in secondary schools. We have a trained group of young peer researchers who are doing the research with us, and that piece of work should be finished by around March next year. So it's a really good example of peer research in practice. And we are hoping to commission another project which will involve, I hope, some training from the Young Foundation later in the ARC's timeline. So thank you from me. I think that's it. I will stop sharing, and I'm grateful for the opportunity to talk about that, and I'm happy to answer questions at the end. So thanks, Mary.
Thank you so much, Felicity. I could listen to that for loads longer and hear much more of the detail. Are there people, if you'd like to ask a question to Felicity, so Savi says, Savi's a colleague at ARC South London, that she'd be interested to hear thoughts on the different routes and associated needs for, one, people with lived experience involved in research who want to develop their research skills, two, people who undertook academic routes to becoming researchers before or in parallel with wanting to undertake research on issues connected with their experience. And I'll maybe just link something to that. I am very used in maternity research to be working in projects which have are not peer researcher pieces of work, but still, for very good reasons, have service user and or public involvement. So that's a whole bunch of issues. I don't know if you'd like to talk on Savi's points and possibly pick up on the point I've just introduced.
Yeah, no problem at all. I'll have a go at answering some of the questions. Like you, Mary, all of the research work that's funded by the ARC in this region, we have really strong public and community involvement, service user involvement, experts by experience working alongside those projects. There is some very good training that we make available to those public contributors to help them to understand research and use their skills, knowledge and experiences to best support research. And sometimes they take on some of the roles as co-researchers. I'm talking here, this community of practice is very specifically for people who want to undertake a piece of peer research where members of the public, people with lived experience, become the researchers. So they undertake a very specific peer research training programme, and then they become the researchers, and that's part of a team alongside academic researchers, but they are the researchers that carry out the interviews, focus groups, data analysis, all aspects of the research project, dissemination and so on. We have a module that's been developed by Northumbria University alongside Cumbria, Northumberland, Tyne and Wear NHS Trust, which is the trust that hosts the ARC. They have developed a 20-credit module for PPI members who want to undertake further training to support their involvement in research. That was piloted last year, is running again this year. It was very successful. Everybody that started completed it. Some people wanted the credits at the end of it, so there was a piece of written work that had to be done at the end of it. Some people just wanted the face-to-face delivery of the materials, but didn't want to necessarily get the credits or didn't feel that they were able to do the written piece of work, but they nevertheless got past the piece of work. Yeah. So that's slightly different to peer research. For me, those slight differences are important. Peer research, I think, is a very specific method of doing research. But alongside that, we absolutely need to develop more accredited training for people who are PPI members, patient public involvement members. I think they're two slightly different things. Savi, I don't know whether that answers your question, but peer researchers for me are people with lived experience. They are not professionals, practitioners, clinicians. They are members of the public with lived experience in a particular field.
Just about got time for a very quick question from Feroza, and then we need to go to our next speaker.
Thank you. Hi. I just wondered how you go about getting more people of colour involved in your research, especially in leadership roles, because I don't see a lot of people that look like me within PPI and PPIE. And that's across the board. I've been doing it for 3.5 years now, and I think like 90% of the PPIE I've been involved in tend to be white British middle class, middle-aged women. And I mean, no disrespect to anybody who is of that background, but you know, we live in a diverse country. We need more diversity. We need more young people. We need more men. We need more LGBTQIA plus people, and we need more people of colour, because that's the country we live in. And I just don't see how, unless you start educating people on the importance of research, and I mean, there is a lot of hesitation and reluctance and fear over research within the South Asian community, for example, you know, so they won't get involved. And I think that you need to somehow get the message out there and get them educated so they realise, and even if it's in the way of, okay, this isn't going to help you necessarily directly, but it's going to help your future generations, because Asian families tend to be, or South Asian, are very, very family orientated. You know, you don't see many of our elders in care homes and things like that. You know, it's multi-generational households, that kind of thing. So if you're to try to encourage them by maybe speaking to faith leaders, going into mosques, synagogues, Sikh temples, you know, and talking to the people that they talk to, and then trying to educate them in the way of, okay, this might not help you, but this might help your children or your grandchildren or your great-grandchildren. And that way, I think you'll get more people of colour involved.
Feroza, thank you for making that point so eloquently. I really appreciate that. And I'm sure that Felicity and others do. We've got other hands going up, but we need to move on to our next speaker. But we must come back to your point.
Can I just, just a really quick, and I won't go on because I know you're short of time, but we do have an enormous amount of work going on in this region to encourage work with people of colour. We've involved a number of faith leaders in the conversations we're having, who work very closely alongside the Jewish community, which is really strong and present in this part of the world, with the African community, with the Eastern European community. So we are working really hard and have a lot of work going on to develop work in that field. So I won't go on, but there's lots of information that we can provide.
Thank you very much. So I'm going to move us on now. Thank you so much, Felicity. Just a little toe in the water, so much that's really got all our, you know, thoughts going. And introduce Kristin, Liabo and Lynne Wright, who are both work at the Applied Research Collaboration in Southwest Peninsula. Kristin as an academic researcher and Lynne as a public collaborator. Over to you for your talk on being a public member co-applicant on research applications.
So I'm Kristin, as just introduced. Lynne, do you want to say a few words about?
I'm Lynne. I'm a member of the PenPEG at Exeter, as you've already heard, and I've been in public involvement for quite a few years.
Thank you, Lynne. So, our presentation is about being a public co-applicant on research programs. And we've actually, we're going to start with a short presentation about what a co-applicant is. And then Lynne's going to share some of her experience of being a co-applicant. We have assumed that you don't know what a co-applicant is. So you might feel, some of you might think, oh, this is really rather basic. But, you know, certainly my experience is that the research world is confusing. I still find it confusing. And I'm not saying that in a sort of, oh, look, even I, as a researcher, find it confusing. It genuinely is. And there are aspects of being a co-applicant that are quite confusing still. And part of that is because it varies a lot. So I'm going to give a very kind of hopefully accessible overview of what this term means before we hear from Lynne. So there's Lynne and me. We have both some experience of this. We're not claiming that we are huge experts, but we do know something about being a co-applicant or involving somebody as a co-applicant in a research team. So I like to think about this. A research study is made out of people, and that is not often sort of foregrounded when we talk about research, because the focus is usually on the topic and what we're going to do, the methods we're going to use, but actually everything happens in a research study. Not everything, actually. There are kind of databases and online things and mechanical and electrical tools we use to analyze data, for example, but really the doers are people. And central to that is the research team, people who do the research. There will always be certainly in a National Institute for Health Research funded study, a steering committee to check on those people who do the research. So a committee that the research team has to report to regularly to prove in a way that they're doing the research ethically and as planned, and that they use public funds in an appropriate way. And then there's the applicant team. So this can be a little bit confusing, I think. You know, you got the research team and then you got the applicant team. That's the team that the co-applicant will sit in, and these are people who plan and are responsible for the research. So the applicant team typically consists of a leader called a principal investigator, or confusingly, sometimes the chief investigator, and often shortened to PI or CI. So that's the kind of person who's bringing everybody together and kind of leading the team. And then there's various co-applicants within that team. So you got a public collaborator, or often called a public contributor, or a PPI member, or person with lived experience. Loads of, in Norwegian, where I come from, Norway, we say a beloved child has many names. And I don't know how appropriate that analogy is here, but loads of different terms for it. But essentially somebody who's bringing their lived experience to the team alongside different methodologists, statisticians, for example, all sorts, and often service providers as well are represented. So what does a co-applicant do? So I'm still not kind of going into the public collaborators role, but more like any co-applicant. So as I said, during the planning of the study, the researcher will bring together a team of people. There'll be a wide range of people, and the co-applicants then form a team of experts who are named on the application and responsible for delivering the study. And then once the research team, you remember the middle team that I showed, once they kind of get on with doing the work, if the study is funded, the co-applicant team will meet regularly to discuss how the team is progressing and action decisions so that the research goes to plan. There is a National Institute for Health Research guidance for public co-applicants. It is a very wordy document. It's 13 pages, and it has information on the roles and responsibilities, payment and support, and some reflections by public co-applicants. But even this guidance emphasizes how the role will vary depending on the study. So it is a kind of starting point, but every institution, every researcher will be a different person. Remember, I started this by saying, research is made up of people, and that gives a certain variety in terms of how teams come together and what people do. I hope that Naomi or Mary could put a link in the chat, or I will do it after the talk, to that guidance, because it's quite a long link, so it didn't make sense to kind of put it into the slide. Okay, so that's very briefly about what a co-applicant is, and hopefully we'll give you a background to the next bit. So I'm going to stop sharing now, and we're going to speak with Lynne about her experience. Yeah. Okay, so Lynne, can you tell us about your the first time you were invited to be a co-applicant on a study?
Yes, I was a carer representative on a research study entitled Care Home Review Project. more than halfway through the project, the person who had agreed to be co-applicant pulled out. And the chair asked if one of us other PPI members would like to take on the role. As no one else offered, I said I would. I had attended all of the PPI meetings, but no other meetings with the research team. Although I had a little knowledge of being a co-applicant, I had no idea of all that was involved. I was asked to write a statement to be included in the submission. I wasn't quite sure what to include, but I wrote what I felt was important to me as a patient carer, from a patient carer point of view, and I sent it in to the lead researcher. I heard nothing back, and I was getting a little bit concerned, so I got in touch and asked if my statement was okay, or if it needed to be modified in any way. I received an apology for the lack of response, and I was told that my statement was fine and it would be included without any modifications. I was then kept up to date by the lead researcher on when the draft report and associated papers were submitted, and thanked for my hard work. I have to say that this was quite towards the end of the project, so I think I only was involved in one meeting with the researchers, with the rest of the co-applicants. It was suggested as well that I register for an NIHR Realms MIS account, and that I also obtain an ORCID number. Now, I had no idea at all what these were. And eventually I back the feedback on the report, and I was very pleased to hear that one of the researchers commented on my statement as an example of effective public involvement. And as this was my first time, that really made me feel good, as you know, sort of, it was quite nice to hear that. So, you know, sort of, I was a little bit elated with that. Then a paper on the study was later published, and I was named as a co-author on it. The research was also presented at the Health Services Research Conference in Birmingham last July, and the researcher acknowledged that I was in the audience. Now, I was able to attend the conference on a bursary from the HSR, with the university paying my expenses. And it was very rewarding to see a study through right from the start to the finish. So that was my first experience of being a co-applicant.
So that sums it up as rewarding, but at times a bit confusing. Is that a good?
A little bit confusing, because I felt I'd been thrown in at the deep end. And although I've been involved in PPI for a number of years, I'd heard about being a co-applicant, but I really hadn't had the confidence to apply.
Yeah, so can you say a bit about the skills you found helpful in being a co-applicant?
Right. Well, first of all, which are very basic, which probably everybody knows, is the ability to use software such as Word, and to be able to connect to Teams and Zooms for meetings, etc. But it's most important that you have the confidence, that you have a good knowledge of the research project that you're going to be involved in. Now, I keep to what I know, and I know today we're mainly talking about children's health and maternity programs. I know very little about that apart from my own experience, so I wouldn't apply to be a co-applicant or even a member of a team to do with anything to do with maternity or children's health care. You also need to be very confident to speak out in a meeting, to challenge researchers. If there's something you don't understand, ask for it to be explained, and ask for it to be explained to you in lay language. I think sometimes researchers don't realise that we don't understand all the scientific terms. Also, you need to have time to read and comment upon reports that are sent to you and emails that are sent to you. You may also be asked to write a report to be included in the submission. This needs to be in good plain English, but to me the most important thing is don't be afraid to ask for help, particularly with form filling and with report writing.
Thank you, Lynne. I think that's really important what you said at the end there, because it's easy to say, oh, you need the skills for being confident, you need to be able to write a report, but actually you shouldn't have to stand on your own and do that on your own. You should get help to do that. And these are skills that can be developed, aren't they? That
Yes.
People can learn. So you don't have to start from I'm confident and I know everything, but you should be able to ask for that help if you need it. That's what we're saying, isn't it?
Yeah.
Absolutely. In your experience, what questions are helpful for someone to ask when they are invited? So say I was inviting you in as a co-applicant, as I'm leading on a research study. What would you ask of me?
Well, first of all, I'd ask the deadline for submission, because you need time, to be able to carry out the work of a co-applicant, and also details of when meetings are likely to be held and how many meetings, etc. But also, how are you going to include me and to use my experience in the project? And how are you going to support me? Because especially if you're doing it for the first time, you do need support.
Wonderful. Thank you so much. So I'm going to just share again some final take-home messages. So just what we recommend, if you are asked to be a co-applicant, is to ask for a meeting to discuss the role and what is expected of that role. Like Lynne said at the end, how are you going to make room for my lived experience, and how are you going to support me in doing this? There ought to be an agreed written outline. And in the NIHR guidance, it says that you should be asked to be put on the indemnity insurance for the study. And that is actually absolutely possible. And the university legal team is able to do that. If they're not able to, you go to your PPI contact, or you explain to the researcher that this is a minimum requirement. And then establish agreements for how you will be paid and what you will be paid for. So being a co-applicant is not something that everybody will enjoy. Just consider whether you will enjoy it. So in our public group, PenPEG, some people are never co-applicants. It's just not for them, but they're very happy to contribute in other ways. So that's kind of one thing that's, I think, worth mentioning. And then that's it.
Thank you so much, Kristin and Lynne. And I myself I'm buzzing with questions from that. I think, we could talk all morning just about that. But we're going to have some further stimulation now, because Dr. Rachel Rowe from National Perinatal Epidemiology Unit and Rachel Plachinsky, who I've had the pleasure of working with on public involvement for many years, are going to talk to us about Listen to Baby. So and public involvement in that study. So I'll hand over to you.
Thanks, Mary. So, as Mary said, I'm a researcher at the National Perinatal Epidemiology Unit at the University of Oxford. Rachel P, do you want to just say hi so people see you as well?
Hi everybody, sorry, it says Je m'appelle James. My brother was doing his French lesson here and I can't change it.
So I'm going to start off. I'm going to share my screen. So Mary asked us to talk about building capacity and public involvement and leadership in this particular research study that I've been running for the last year. So we're going to do a little bit of a double act. I'm going to talk first and then Rachel's going to come in as well. So I want to start by I'm going to start by telling you a little bit about what the research is about, because otherwise it's impossible to understand what we've been doing in PPI. And then we're going to talk about building capacity and PPI leadership, how that's going. We're both going to reflect on that. And I'm going to come back and talk about a little bit about the other PPI that we're doing. I feel a bit bad actually, because the two people that I'm going to be talking most about aren't able to be here today. I feel like we should bring them back another day and hear what it's been like from their point of view. But Rachel and I are going to do our best. So the background to this project is that national guidance recommends, we're talking about women who are pregnant here because that's what I do. I do maternity research. So we're talking about women who are healthy with straightforward pregnancies, and national guidance says they should be looked after by midwives during labour. And we're interested in monitoring, and national guidance says that midwives should listen to the baby's heart rate using a handheld device regularly. So in this picture, you can see it's kind of a Doppler ultrasound machine, and you can see that the midwife is holding it against the woman's tummy. And midwives call this intermittent auscultation, which literally just means listening every now and then. So national guidance says that this is the best way of monitoring the well-being of the baby for women who are healthy with straightforward pregnancies. There's no benefit to using the kind of electronic monitoring that people might have seen where you have a belt around your tummy. There's been clear guidance about how often midwives should listen, when they should listen, since the 1980s, and that's unchanged. There's no guidance about what device midwives should use, and there are lots of different kinds of devices. How they should count the fetal heart, so the fetal heart's going at about 120 beats per minute. How should midwives count what's going on there? No guidance about that either. So the kind of practical bits we don't really know much about. So what's the problem? Well, we know that midwives don't always do what they should be doing in line with guidance. We know from research studies that they don't always listen at the right time, for long enough or often enough. They don't always record the fetal heart, the baby's heart rate properly. And we know that sometimes this contributes to severe injury in babies or even the baby dying. And we know that this doesn't happen very often, these poor outcomes, but we know that this kind of monitoring is used a lot. So in around 300,000 births a year in the UK, and it's used widely across the world. So I'm a researcher, so I always kind of say, well, you know, what do we know? What's the evidence? What's the research say? Basically, there isn't any. So there's no research about how midwives should listen to the fetal heart, the baby's heart rate, when, how often, how long, what's best in terms of counting. No evidence about what device is best. No research about how midwives do this kind of listening. No research about what it's like for midwives. No evidence about training in this key part of midwifery practice. So this project aims to shine a light on some of those issues, aiming to improve the quality and safety of this kind of monitoring by helping us understand a bit more about what's going on. So what's the organisational context and the practice context in which midwives are doing this part of their practice, and to use that information to develop a range of solutions to the problems. So what we call a toolkit. It's a 3-year project, and we've been doing, we started about a year ago. So, and we have 5 separate work packages. We've done a national survey to find out what midwives are doing. We're going to watch midwives in practice and talk to them about their experience. We've talked to women about their experience. And then we're going to bring everybody together to co-design solutions to the issues that we've identified. And we're going to test it. So that's what we're doing. So when we were thinking about the project, how do we plan our patient public involvement, in fact, parent involvement? So when we were planning PPI, when we were developing our funding application, the approach that we're using, experience-based co-design, brings everybody together. It listens to everybody. So we're kind of embedding involvement of parents, women in this case, throughout. But we knew there were some ethical challenges where we wanted our approach to be driven by women's experience. And in particular, we wanted to hear what women thought about our plans to observe midwives while they were looking after women in labour. And we also wanted to know what women would think about our plans to collect data from women's notes about midwifery practice. I was really interested and gratified to hear the comments earlier about inclusion and diversity. And we started the project with a very explicit commitment to equity and diversity and inclusion throughout. I really didn't want our public involvement to be involving the kind of usual suspects that were referred to earlier, sort of white middle class women. And we were quite conscious that a lot of the research team were white middle class women. So when we were thinking about our co-applicants, this is really well planned, Mary, because this follows on so well from what Kristin and Lynne were talking about. When we were thinking about our co-applicants, we identified fairly early on in the planning of the project 2 women who I wanted to invite to be co-applicants, and now they are co-investigators, so they're involved in the project. Partly because I'd met one of them before, and I talked to Rachel about who might be good to work on this project. They were involved from 3 months before our first application. So grant applications typically involve a 2-stage process. You have to fill in a load of forms for a stage 1 application, and then you find out whether you've been successful, and then you have to fill in even more detail for a stage 2 application. So it all takes it takes months, it takes so long, and that's one of the things I think that people don't always appreciate. So Mo and Samaya were involved from 3 months before we put in the stage 1 application. We'd only met once or twice when we first started this online, and we didn't know each other very well. They were involved in all our co-applicant planning meetings, so putting the funding applications together. And they had quite a meaningful contribution to the application, actually. They asked really helpful questions, and particularly in the key areas that we were interested in addressing in terms of the things that might matter to women who were involved in the study. Because of their relative inexperience, we agreed that I would, as the chief investigator, would be the PPI lead on the study, and that's a kind of formal role that NIHR require. And we also built in mentoring for them from Rachel P. So essentially support for them throughout, so that they would have somebody to go to ask questions of, for support, for anything they wanted, really. So I'm going to talk a little bit about my reflections on how that's gone and some of the issues that arose for me, and then I'm going to hand over to Rachel to talk about her perspective. So I think it was Lynne that said that it was really in at the deep end, and it really was it really is in at the deep end. I think when you start doing this on a project like this, there is a huge amount to learn. All the different systems, the different forms, the different research methodologies, it's really complicated. And I should say at this point that Mo and Samaya have 7 children between them, 7 primary school age children. So they're busy women, and that is one of the issues that we deal with quite a lot in our research, is that the women that we really want to hear from are really busy. They've often just had babies, they've got young children. And the other thing that I've said PPI going native, and I think that that's because one of the things I realised quite early on, and I'm going to click on to the other 2 points as well, because they're all really related, is that Mo and Samaya didn't really know what they didn't know. So and I was very reliant on very experienced patient and public involvement people like Mary, like Rachel, who'd done this a lot before. And so what I realised quite early on was that they weren't necessarily giving the input that I wanted or expected from them, from their own experience. What they were doing was trying to learn as much as they could about the research process and commenting on research methodology and survey tools and things that I thought that I hadn't anticipated they would be interested in. It was really interesting and useful to hear their comments. But I had a conversation with Rachel at one point where I said that what I really want them to say is to think about things from the woman's perspective. And they weren't doing that, and I couldn't get my head around why they weren't doing it. And obviously it's partly because they didn't know and we hadn't talked about it. And so we were kind of both learning together, all of us learning together. And I can talk a little bit more about that in the chat, if that's helpful. We also had to convince, having said all this, I had to convince NIHR that we needed a PPI mentor. So Mo and Samaya had done a little bit of PPI on another project with Rachel before. They'd never been a co-applicant on anything like this before. They have experience locally in their area of being running a peer support group or working on providing advice to their local NHS trust from a kind of women's perspective. And I think NIHR thought, well, that's great, they don't need anything else. So I had to justify why I thought we needed Rachel and the support that Rachel would provide for them. We're still learning, all of us, and we're in a really, really good place. I have to say, they're absolutely brilliant, and we've really, really learned a lot. And we're really, all of us still learning. So it's a hugely positive experience for me. I'm going to hand over to Rachel now to give her perspective. So you're going to have to ask me to move the slides on, Rachel.
So yes, thank you, buddy. Excuse me. I put this picture on here. I've been doing PPI since 2008. And I put this picture here because sometimes when I talk to researchers, especially about this, it looks like I've had a really, step by step, and I've built up my experience and everything. But actually, in reality, it's felt more like, the Escher stairs where they're going everywhere and up and down and all over. So yeah, it's not felt like a straightforward process. And I often reflect on my process because of the fact that I've got to this stage where researchers such as Rachel are saying to me, oh, I've got some new reps, which I'm all for because I feel like I'm a long way from having had a baby, and I do primarily work in maternity. But I keep thinking, well, how have I got to where I've got to? Because I've been here, like I said, doing it with Mary since 2008. And since the very early days of PPI, and things have changed a lot, and we've all learnt along the way. There's not been a sort of a built-in structure that for us to follow. It's been kind of follow your nose and see what works a lot of the time. So next slide, please, Rachel. So yeah, these are my steps, and as I say, it looks fairly straightforward, doesn't it? And as I reflect on things, and I do always have to acknowledge the fact that I really did have a head start on a lot of people coming into PPI because I was an NCT practitioner. I first of all trained to do NCT antenatal classes. And although I have sometimes found myself falling a little bit into the trap that Rachel mentioned of going native, at the same time, I was very accustomed already to reading quite complex things and thinking, right, how do I make that into a form that's more digestible to the parents that I'm going to go out and engage with? So that's an automatic reaction for me, and one that I'm always trying to think of tactful ways to say to other parents. And yeah, I've seen lots of different stages, and I've been a rep on many different sorts of projects in all kinds of roles. And I did have an unofficial mentor myself. Well, I had Mary, and I also had someone called Jill Geit, who's been involved for even longer than Mary and I in maternity research, and is very much still around to tell us about, when things fell apart and then when they came back together in different formats. And I'm working with other experienced reps as well has been really helpful. So I do work a lot with Charlotte Bevan, who also works for the Stillbirth and Neonatal Death Society. So next slide, please, Rachel. So yeah, I helped Rachel find Mo and Samaya. I'd worked with them on a previous project called Birth Timing 2. Mary was involved in Birth Timing 1. We developed a structure within Birth Timing 1 where you had these three different levels of involvement, from co-investigators down to an advisory group, down to sort of wider engagement with parents about the project in its. So we sort of developed that a bit further for Birth Timings 2 as Mary stepped back. And I went along to a National Maternity Voices event to talk about the results we had so far and where we wanted to go with the next set, which included bringing more diversity into our group. And that's where I found Mo and 2 other women who were also MVP reps. And I recruited Sumaya, who's on my local MVP. And as Rachel said, I knew already that she was very involved with setting up a support group for women who were of South Asian descent. There's a lot of women from both India and Pakistan in this area, often now 2nd and 3rd generation. But obviously they've got quite different often outlooks and concerns to women who are white British and have always lived in Yorkshire. So and Mo is Black British. She describes herself as Black British, and she lives near London. So yeah, we brought Mo and Sumaya onto the advisory group, and I have to say we were all very lucky in that the application for this project, we actually had a lot of freedom to shape the PPI together as we went forward. It was a data linkage project using things such as routine data sets from the Office for National Statistics, hospital episodes statistics, and all this kind of thing. And it very quickly became apparent that we had to explain how that worked to our PPI panel if we wanted them to be able to contribute constructively to the way that research was unfolding. So we did that. We spent a lot of time talking about data sets, about their topics of interests, and we actually produced some guides for parents and maternity activists, as we call them, on how to access publicly available data so that they could find more out about the things they were interested in. So yes, I'd got a well-established relationship with them. The 2 of them were very used to working together as a team. They'd spoken at a birth timings event as well and presented more about their findings. And if you just go to the next slide, Rachel, you'll see some of their feedback from being involved with that they really enjoyed it, basically. They both said they were quite geeky. They loved getting involved in this sort of thing. They loved working together and thinking forward. And I did find it very interesting also that they're both teachers. I think Mo's primary and Sumaya's secondary, but they're both teachers. So again, they've got that. They're in that habit again of thinking, how do I explain this to an audience that doesn't, they can talk to people, they can explain things to an audience that doesn't understand it. And I feel that project did a huge amount. That being involved at that level gave them a huge boost in, and then took them forward into the Listen to Baby project, feeling that they'd got a lot to build on, if you like. So next slide, please, Rachel. I'm just looking at the time as well. So thinking again about, what do we need to build effective, I call them parent reps, because it's all maternity that I'm working with. And I think often the things that I've come across in the past of people have been quite technical. So you see that bottom point, people have got about the technical knowledge. I need to know about acronyms. And you can find that. I personally think that's relatively easy to acquire. Having said that, I went into PPI coming to the end of a master's degree, feeling I knew everything about research there was to know, and then doing it and finding out that actually I didn't. So yeah, even you could have all this training and think you know, but actually you don't. And I think the step up as well, important between being part of an advisory group and then going on to being a co-applicant and a co-investigator. It's that movement from someone who sits there and makes suggestions to someone who makes suggestions but also has to go away then and think about how you make them happen. So helping people to step up, process by process to doing these things is really important. And it's thinking about, I feel a lot of my role is supporting people to find and build support networks that they need to be effective, to feel that they can move forward, that they can take this outsider perspective. They're not researchers. They're part of the research team, but they're not researchers. So they can take that perspective that says, do you actually realise you're using that language, such as not clinically significant, but to a parent, that event that you're talking about is hugely emotionally significant, even though it doesn't have clinical significance. So it's that level of challenge and thinking, can you take that broader perspective? Can you remind the researchers about how their more focused approach is going to be received by a wider audience? Do you want to do your final slide?
Yeah, so I can skip my other PPIE slide, Mary, because it just describes the other things that we've been doing, and we've had some challenges with, including involving women who don't speak English that we're also working hard on. And I'm just going to finish with I just want to let everybody know, everybody else who's involved in the project. Thank you.
Thank you so very much. And thank you to all of our presenters. I think it would have been great if we'd just had a whole 90 minutes with one presentation, but because they are so rich. But I also think it's very interesting to hear the kind of different perspectives that people come from, the different interests people have, the different language people use, and the way these intersect. And I'm sure a lot of that is not yet entirely clear to any of us, but it demonstrates why it's so important that we do collaborate and learn and discuss and publish. We're really coming to the end now. So we wanted, Naomi and I, to let you know that we're hoping to do a report from these webinars because we think there's so much really important learning. And those of you who were facilitators, if you'd send a couple of paragraphs on the things that came out in the breakout groups, we'll include those in our reporting and make that available to everybody. Naomi and I, I'm sure, have got an awful lot of reflection to do after this meeting. We're going to send you a link or a feedback form on an email in the next couple of days. Please would you return that to us, and we will follow up from there. And many thanks for all your contributions today, and I'll just hand over to Naomi to round us up. We've got the link now so that you can book for webinar 2. I hope that you'll come back, and we're very keen to continue this conversation. So many important things have been raised, and we've got the opportunity to learn more together from each other in October and again in November. And any thoughts, any comments, please send them in your feedback. And finally, please, a big round of applause for all our speakers and contributors today. And see you next time. Thank you.